Recovery Reform is a podcast that provides educational content while addressing the stigma against drugs and the people who use them. Expertise meets lived experience as the hosts and their respective guests unpack the multifaceted cause that is recovery reform. Welcome back to the Recovery Reform podcast. I'm here, as always, with my co-host, Dr. Taylor Nichols. And we have an amazing guest today, Dr. Lance Dodes. Lance Dodes, MD, is a training and supervising analyst, Emeritus, at the Boston Psychoanalytic Society and Institute, member of the faculty of the New Center for Psychoanalysis, and retired assistant clinical professor of psychiatry at Harvard Medical School. He has been the director of the Substance Abuse Treatment Unit of Harvard's McLean Hospital, director of the Alcoholism Treatment Unit at Spaulding Rehabilitation Hospital, now part of Massachusetts General Hospital, and director of the Boston Center for Problem Gambling. He is the author or co-author of 3 books. Number 1, The Heart of Addiction. Number 2, Breaking Addiction, the 7-step handbook for ending any addiction. And 3, The Sober Truth, debunking the bad science behind 12-step programs and the rehab industry. Dr. Dodes has been honored in the Division on Addictions at Harvard Medical School for distinguished contribution to the study and treatment of addictive behavior, and has been elected as a distinguished fellow of the American Academy of Addiction Psychiatry. He has been asked to lecture across the United States, Canada, and Europe about the understanding of addiction he has developed. First of all, thank you so much for being here. I really appreciate you taking the time. And I kind of want to hop right in, and I'd love for you to kind of expand on, the kind of compulsive model or the psychological compulsion that you speak to, if you're open to expanding on that.
Sure, and thank you for having me. Well, I often like to explain my ideas by giving an example because it's easier to relate to an actual person, and this is an actual person. And we can stop in the middle if it goes on too long. But this is a case of a man who had alcoholism. And at the time of this vignette, he had been sober for 6 months. He was in therapy with me. And he came in one day and he said, "Well, Doc, I blew it. I drank." And I said, "What happened?" And he told me this story. He said, "Well, I went downtown with my wife we were going to do different things. So what happened is I parked the car. I dropped her off and then I parked the car. This sounds unimportant, but it actually is. And then I parked the car and then we agreed we'd meet at a certain time at a certain spot." So he said, later, he showed up at the time and the spot, but she wasn't there. So he waited and waited and waited. She never showed up. Now, this was in the days before cell phones. So he couldn't just give her a call. And he couldn't go back to the car to wait for her because he had parked the car after he dropped her off. She didn't know where he was. So at that moment, he said he spotted a bar across the street down a block. And he went in and he got a drink. So that was the story. So I said, "Well, let me ask you a question. I said, first of all, did it help?" He said, "Yeah." So I said, "Okay. When you walked in the bar and had the drink, when did you start to feel better?" And he started to say, "Well, I was drinking it." And then he stopped himself. He said, "When did I start to feel better?" "I started to feel better when I ordered the drink." I said, "Huh." And then he thought about it some more and he said, "Actually, if you want to know when I started to feel better when I walked in the bar. I started to feel better." I said, "Huh." And he thought some more and he said, "Okay." He said, when I first started to feel better? When I was standing on that street corner a block and a half away and I decided to go get a drink. That's when I felt better." So this is a story I've heard from lots of people. And it clued me into the fact that there's something happening in addiction that doesn't really have to do with having alcohol in your system. It has to do with something else. He had solved whatever his problem was He had solved it by just deciding to get the drink. So what was it? Well, we talked about it. The problem was that he was stuck. He was trapped in that street corner. He couldn't go to his car. He couldn't find out where. He just had to stand there. Now, anybody could have been in that position without having to have a drink. But for him, this meant a kind of helplessness that he couldn't stand. And we should know why that is, but I'll talk about who he is. But there was something about him that made that kind of helplessness overwhelming for him. So to generalize, this is just an example, of course, but to generalize, what I have found is that in every addictive act, it is always preceded, and you might say caused, by feeling overwhelmingly helpless. Different for different people. All the circumstances are different. But my books have a million examples of different people with different things. But from that standpoint, the first part of my idea is that the function of addiction, psychologically speaking, is to reverse a state of overwhelming helplessness. It works because you're not helpless. The reason he felt better just by deciding is because now he wasn't helpless. He could do something. He wasn't just standing there saying, I can't do anything. He can do something. He can do something that he knows will make him feel better. That's the opposite of being helpless. So that's the first part of it. And maybe I should stop here and say a word about why this man in particular had such a hard time with this. Yeah. When he was a child, he was an only child. And he was what sometimes is called a latchkey child. His parents both worked. And when he would come home from school, he lived close enough so he could walk home. But he walked home, and the key to the front door was under the mat. So he would get the key, and he would let himself in. It's from a very, very young age. He was 4 or 5 or so when this began. And he got into the house, and he waited. He waited and waited for his parents to come home. And for him, this was very hard. It was a big, empty house. He was young enough so that he really couldn't, it frightened him to be alone without his parents, and he just waited for them to come home. So this was a kind of experience which had an important impact on him. You might say, why would this particular thing be so important? You'd have to know even more about him. But take my word for it, being placed in a helpless situation like that, especially one where he was waiting, was overwhelming for him. It reawakened all this. So that's why it was too much for him. Okay. So the first part then of addiction, would I say, has to do with a way to treat, to reverse this overwhelming helplessness, which it does. The second thing is states of overwhelming helplessness are well known. We all know about it just by living. When you get to that state, you really are not in good control. And it's not abnormal. The example I often give is somebody who is exploring a cave. Now you're in there with your equipment and everything, and all of a sudden, behind you is an enormous rumble, and 3,000 tons of rock fall between you and the opening. Now you are helpless. You're trapped. So what happens? Well, the normal response is to go nuts, is to be enraged, really. You hit the rocks, you do whatever you can. Nothing else matters in that moment. You might even break your wrist hitting the rocks, but no one would say you were self-destructive. So there you are doing that. It's because the challenge of overwhelming helplessness is a challenge to what we in the field call healthy narcissism. It says you should care about yourself, and if you're trapped and helpless, that's a big problem. In fact, the reverse, let's say that the tons of rock fall and now you're trapped in the cave and you don't hit the rocks. You don't fly into what we call a narcissistic rage. You don't fly into that. You sit down and you wait to die. That's not a normal response. We also know from the experience of people who have been imprisoned or in concentration camps that the people who survived best were the people who found a way to fight back, even if it was only keeping track on the wall of the number of days or some other form of quiet resistance. The people who actually did say, okay, I'm going to die, died, many of them. They got very depressed and died. So that's not a normal response. I'm stressing that because at the heart of the addictive psychology is something quite normal. It's not, the result is not normal, but that kind of rageful response, that's kind of out of control thing, follows from being overwhelmingly helpless. And later, of course, people past that moment, they're filled with regret. They wish they hadn't done it. They promise not to do it again. But that's all it is. That also addresses the issue that the incorrect issue that people have had for years about folks with addiction, that they are immoral, or that they're stupid. Why don't they realize, or that they have a death wish or something? None of those things are true. Okay, so if the purpose is to reverse overwhelming helplessness, and the motivation, the energy behind it, the drive behind it is this kind of rage, normal rage at overwhelming helplessness, that leaves one more piece. Why did he have to have a drink, though? Where does alcohol come into this? So it turns out that to explain this, let me go back to the beginning of the story. So I said he was helpless, right? But was he? Actually, he wasn't, because he could have gone home. He knew where the car was. He could have said, tough luck, wife, I'm going home, and you're stuck. I don't recommend this. But he could have done it. So the question is, if that would have solved the problem, it would have created other problems. But if that would have solved the problem, then he wouldn't be helpless anymore. But he didn't let himself do it for the obvious reasons. He loved his wife. He didn't want to be abandon her and all of that. But he still had to do something. So psychologically, what it means is that instead of taking the direct action that he could have taken, he has to take an indirect action or a substitute action. Now, the addiction, what we call an addiction, depends on the choice of substitute action. So this man was an alcoholic because when I say chose, it wasn't a conscious choice, but he did that. But let's say we have another person in exactly the same situation with the same feelings. And he comes in and he tells you the story that when he got to that moment, he had to go shoot up some or snort up some cocaine. Now he's no longer an alcoholic, he's a cocaine addict. But here's a better example. Let's say he said, and let me change it to a woman because this is the real case that's in my book. Let's say she said, when I do that, I have to clean the house. I am a compulsive house cleaner. Same issue, exactly the same issue. She has to do something. By the way, why does cleaning the house work? Well, when you clean the house, you're fixing your life emotionally, right? You're saying, I'm going to get everything in order. Nothing is out of my control. I've got it all. So it's important to understand that, and this is why it's a compulsion. The compulsion to use alcohol under those circumstances is exactly the same as the compulsion to clean the house for another person. And they are no morally different. One person is not, okay? You got it. So this is my problem also with the common nomenclature to say that people have a substance use disorder. To say somebody has a substance use abuse disorder is like saying somebody has a compulsive house cleaning disorder. It's not a disorder, it's a symptom. And people often change the symptom. Not always, but often. I used to run the largest compulsive gambling clinic in Massachusetts. So we saw people whose life history of addiction they often were in their 30s. Most of our people were in their 30s. But when they were teenagers, they used everything on the street. They were poly-drug abusers. They got into their 20s, and that tended to fade, and many of them became obvious alcoholics. By the time we saw them in their 30s, many of them had stopped using any drugs, and they were now compulsively gambling. So the current crazy way that we think about things is we would give them 3 diagnoses: poly-drug abuser, alcoholism, compulsive gambling, which would be harmful because it suggests to them, you got 3 things wrong with them. It doesn't point to the problem. All they have is a compulsion, which is, I believe, produced in the way I described, and it just switched the substitute, or we call it a displacement. They just switch the displacement from one to the other. And it's helpful for the person to know that too. So, so that's the compulsive nature of addiction. It's a long-winded way of saying it.
Very, very amazing the way that you put that. And for those that are unfamiliar, briefly, can you explain what a compulsion is for people who may not even know what that is?
Yeah, I mean, it's, I think actually everyone sort of has a sense of it, which is right. It's something that you feel you must do. You are overwhelmed, you have to do it. And most compulsions don't bother people very much. I have to arrange everything on my desk so that all the lines are parallel to each other or perpendicular to each other. I have a compulsion. I get very upset if I can't do that. Well, no one is going to send me to a 12-step group to talk to other people who arrange things parallel on the desk. But it's the same kind of issue, right? So, and again, the only importance of it, the language doesn't, the word doesn't matter so much, but if you understand that addictions are compulsions, it changes everything, because then you treat people the same way, you know? And by the way, let me just get back to one other thing about that. So I said my man, I told you a little about his background, how it was overwhelming for him. It had been traumatic for him as a child to be left alone and have to wait. So when you treat somebody with an addiction, you help them ideally to understand this whole system for them, how it works for them. It's different for different people. One of the advantages of that is that once they understand what it is about them that triggers them to feel overwhelmed, then you can predict the next time the addictive urge will come on. And that happens all the time with my patients. And not only can you predict it sometimes a long time in advance. I had a patient who I can talk to about later, but whenever she threw she liked to throw big parties, and whenever she threw a big party, she had very severe alcoholism. But she would stop drinking for the party, and then she would drink enormous quantities of alcohol as soon as it was over. But it didn't happen so much at other times. So she knew, and I knew, 2 weeks from today, you are going to have a drink. You are going to be overwhelmed. How could we know this? Well, because we understand what it's about for him, for not just the history, but why it bothers him. So actually, the point I was trying to make is that in psychotherapy, not talking about addiction, but in any good psychotherapy, that's what you find out. You find out what is the most important problem for that person, which is causing their symptoms. So the therapy for addiction is good therapy, with the addition of this piece of understanding how it works, where people feel overwhelmed, and then instead of feeling that they're bad or immoral or stupid, that this is a kind of rage which restores you against helplessness. But then it becomes like a therapy, like any therapy. And people are treatable, is the other way. It means if you treat them that way, they are as treatable as anyone else.
What are your opinions when it comes to people utilizing terms like substance use disorder?
Well, look, I think it's inaccurate, and no one would care it's inaccurate, but it's also harmful, because when you tell somebody they have substance abuse disorder as if it's a condition, which doesn't exist, by the way, if you tell them that, then they say, okay, how do we treat substance abuse disorder? And you're already looking in the wrong direction. I have no idea how to treat substance abuse disorder because I don't know what it is. Now, if you say, what is this compulsion to use a substance? That I can treat. So it's harmful, and it's been enormously harmful. I mean, as we know, most treatment in this country is, I don't want to say ignorant, but it's ignorant. I mean, they just don't know. So what do? So they are supportive, like in AA, they're supportive, they care, they give you rules, they give you a whole system, actually. Unfortunately, that doesn't address the problem. And that's why, the AA success rate is so extraordinarily low. In the last book, we looked at all the studies, and the success rate was between 5% and 8%, if by success you mean people stopping drinking. So that's no shock. You have about the same percentage, by the way, if you're treating another kind of group treatment. Let's say you have, groups can be very helpful, but let's say you have a grief group for people who are grieving. Well, it's very helpful. Does it really solve the problem? No, but it's helpful. And you can have a group for all kinds of things. So Yes, that's how you get the 5 to 8%. But the harm from it is enormous because, unlike a professional organization, which studies its results, changes it, you mentioned evidence-based treatment, you try to figure out what's best on the basis. AA doesn't do that. It hasn't changed since 1935. So they don't, I'll come back to this in a minute, but they don't change their treatment based on the results. The fact that it has such a low result doesn't mean anything. In fact, they sort of blame the patient. If you're not getting well, do more meetings. Do 90 meetings in 90 days, right? Get with the program. Stick with the program. Well, I haven't done well for the last 5 years. Well, stick with it. So it's sort of the patient's fault. I mean, I don't know anyone who has been to AA who's ever told, AA isn't for you. Why don't you go see a good therapist? I don't know anyone who says that. So, yeah.
Yeah, let me jump in really quick.
Sorry,
go ahead, Taylor. Go ahead. We got it.
I was gonna say when you create a model, when you create a system that has this or essentially self-fulfilling prophecy that failure is the fault of the person and not the system,
right,
then it's unfalsifiable. You can't challenge it because it flies in the face of their own model. It's not the model's failure, it's the person's failure to follow the model. And so you have an unfalsifiable claim because yes, people who don't follow the model specifically are failed by the model, but the model says they're failing the use of the model. And so when you have a system like that, it is inherently designed not specific to a person. It's only designed to succeed for the people it works for. And then they can claim, well, it's 100% success rate. It works for the people it works for. Well,
exactly.
Of course, because that claim is inherently, you can't challenge that.
Right.
So that's the basis of a model like a 12-step program is, oh, well, you didn't work the system. You didn't work the steps. You didn't work the model. And that's not true. The model doesn't work for everyone. It may work for some people, and that's fine. But the model didn't work. And then the defense is, well, you just didn't follow the model. And so you can't challenge that. And so it's not evidence-based.
No. No, certainly not. Yeah, the AA slogan is "It works if you work it," which is not true. You mentioned the Stanford study, and let me say a word about that. The Cochrane collaboration did a study in 2004, I believe, in which they reviewed all the literature on AA, and they found that it was ineffective. Basically, that was what they found. In fact, they did a study comparing AA with several other, what I would call non-psychologically sophisticated treatments, motivational enhancement therapy, and none of them worked. So they said, that's the result. They repeated the study about 5 years ago. And the result, which was, as Macaulay mentioned, has been widely loved by the people in AA, is actually, if you look at that data, first of all, about half of it is the same data from the previous study. And that's important to say because many of these experiments are quite small. But there was an enormous study, which contributes a lot to the statistical outcome, called Project Match. Project Match was in the 1990s. It was a huge study to try to decide which treatment was best. That was the study that the Cochrane collaboration mostly reviewed, which said nothing worked. So that data was in this new study and heavily contributed statistically. There were some more studies done by the authors of the Cochrane report, by the way, for what that's worth. But they only studied the same ineffective treatments. The psychotherapy, ordinary psychotherapy, even with or without understanding what I'm talking about, was never included. It's just not in there. So they looked at the same thing. They looked at some CBT, they looked at some motivational enhancement therapy, they looked at some other stuff, which I don't remember. None of them, or let me put it this way, they all work the same. With the no comparison group and no control, they found out what they already knew. Yes, you're right. it works for some people, 5 to 8%.
For those that are unfamiliar, briefly, or people are trying to dispute that there are people within 12-step that are basically blaming individuals for it not working. It clearly in the literature, it labels people as constitutionally incapable of being honest with themselves, and goes on to say that they are such unfortunates. They're not at fault. They seem to have been born that way. They're naturally incapable of grasping and developing a manner of living which demands rigorous honesty. Now think about how messed up that is to say that to someone who maybe needs a different approach. You know what I mean? And this is just the reality of the situation. And these conversations need to be had, not in some attempt to invalidate those that have found success, but to maybe advocate for the individuals who haven't found success, and maybe advocate for the people who have, so that they can not be abusive towards people who are having challenges.
Let me say one thing. Bill W., who founded AA, stopped drinking. But as I would have expected, he then developed several other severe addictions which killed him. He couldn't stop smoking. And he developed terminal lung disease, and he couldn't stop smoking then. And this is widely reported, it was known. So even when he was told, you are going to die, which he did, he couldn't stop smoking. So he shifted the displacement or the substitute from alcohol to cigarettes, and he died. So how effective was his treatment? Ineffective. It helped him to stop drinking, but it didn't change anything about the problem inside of him.
Yeah, from my understanding and looking into the history as well, is that he basically became a victim to his own rhetoric. At that point, this dogma had been solidified. And so then when he was looking into, using LSD, and his relationship with Aldous Huxley and all these other encounters, I think for him, he was realizing that there were many things that had not been addressed, and was actually seeking something out and trying to figure out what he could actually do. But at that point, it was too far gone, and that it was set in stone, and so there were, people will often then kind of invalidate him, and I'm not insinuating that's what you're doing at all, but within 12-step, actually, there's a lot of people who will, bring up the fact or the claim that he asked for a drink on his deathbed, and really all that shows is that he wasn't given an effective option. So it doesn't really speak to his character. It speaks to the ineffective nature to the program that he co-created, and look, I'm not going to go too deep into this, but into that rather. I want to go into this, and then Taylor, I'll give you the floor because I've been kind of hogging the mic here. What do you think about the abstinence violation effect in regards to 12-step?
I didn't hear what you said. What is it?
Well, what are your thoughts on the abstinence violation effect in regards to 12-step? And if you're unfamiliar with that, then
you lose your tips, you lose your account. Is that what you mean?
So basically, just so we can go into something that let's go into what are your thoughts on the specific harm that can be perpetuated by 12-step from a clinical perspective? Yeah.
I think we have all seen lives destroyed by folks staying in a treatment which is ineffective for them, as it is again for most. But they are told to stay in, even if they're not said this is your fault. That's the message, right? Stay in it. It's not working, but stay in it. You got to go to more meetings, and years go by. So I've seen any number of people who've spent decades in AA, never stopped drinking for more than a short time. And their lives have been ruined. Their marriages are over. Their friendships are over. They've lost jobs. They just never had the proper treatment. So yes, it's been horrible. And by the way, there's a political component to this too, because unfortunately, AA has become enormously politically powerful. And I don't know every state, but I know there are several state, I guess they're now called substance abuse divisions, or some division of the health departments of states, which are run by AA people. And I also know that there are employee assistance programs that are run by AA. I happen to know that because for many years, I was a consultant to the FAA and to some of the airlines. And when you had people who nobody wants to have a drunk air pilot, but they would send these people to me after they had treatment. And, 100% of these people were not drinking by the time I saw them. And I said, that's great. I said, what's the plan going forward? Well, there is no plan. The plan is to do the EAP recommended thing, which is to go to more meetings. So every time I cleared somebody, and I cleared most of them because there's no reason not to clear them at that point. But I finished every report by saying, this person, this is what you should really be doing, which was completely ignored. But then there are a lot of EAP people who get fired, where I get cases where the person has been fired from his job, not airlines, because they were drinking. Well, okay, if they're not doing their job, then fire them. But they were doing their job. They were just drinking. They didn't like it. I had one person who was fired because he was smoking marijuana in his car when he was in the parking lot before coming into work. And he had an exemplary record. He had an outstanding record. It was never a problem. They fired him because you said you can't smoke marijuana. You can't be a marijuana addict. It was crazy. Anyway, I'm sorry if I got off track there.
No, I think those are all perfect examples, though. And I can only imagine how frustrating that must be to have these authoritative bodies ignore your recommendations when you're the consulted expert and you're saying, hey, the model that you're using for managing this problem that you've consulted me for as an expert is invalid, and I'm recommending something different, and you don't want to hear it, even though you are literally paying me to be the expert consultant.
Yeah. To be a little positive, I have been a consultant in a few cases in court where we won finally, and there was one in British Columbia in Canada, in the province. I once was asked to speak to all of the Supreme Court. There are multiple Supreme Court justices in British Columbia, to ask them, how do we deal with people with addictions? So some people listen, but most people don't.
I would be so frustrated. I do. I want to speak a little bit to what Macaulay was talking about with the abstinence violation effect. Talking about one of the harms that I do see is that people will say, like, well, if I already violated my abstinence, if I already broke, lost my chips, whatever, then I might as well go all in, right? Or start using the other things that I had previously enjoyed using, but have been abstinent from as well. So, and that there are certainly harms to that idea, and that the specific model of AA in codifying these days and making it such that and return to use in a compulsive, condition or disorder, or however you want to frame it, that condition is defined almost by ongoing compulsions and returns to use until that problem, the underlying problem, is solved for. And that if you have that, if you haven't solved for that problem and you have that compulsion, you return to using, then you've lost all of your, earned, in the case of AA, your earned status, your time, and that is what drives further depth into using and that sort of ongoing compulsive behavior. And so to use that frame of compulsion, how would you think of that or correct for that in the face of something like an AA or that abstinence violation effect idea?
Yeah, I couldn't agree more. I mean, it's just wrong. It's stupid. I mean, if you have someone who has been drinking every day for the last 10 years and now stops drinking for 6 months and then has a drink, that's a success, But in AA, he has a drink, or let's say he has even a week of drinking, then he stops again. So over the past year, he's drunk, a handful of days. That's wonderful. But as you point out, in AA, you go back to day one, and there is no other area of psychology or medicine, for that matter, that looks at it that way. If you have high blood pressure and they're trying to manage it, and it's a pretty good management, and then one day you spike, you don't go back to zero. You say, okay, something came up that we'll see if we can fix that. But for diabetes, sugar levels, I mean, it's great. Nothing like that is that you're back at the beginning. It's discouraging. I completely agree with you. I've heard lots of cases like that where people say exactly what you said. I might as well, you know. And it's bad for self-esteem. It says, oh, I failed. You know, I fell off the wagon. Terrible.
This is not just some phenomenon that happens to some people, and that's what's so interesting about it, is because fundamentally built within 12-step is the threefold disease model. And for those that are unfamiliar, that's the physical allergy, the mental obsession, and the spiritual malady, which none of these have any basis in any sort of like clinical stuff or anything medical. It's, you know, completely not true. And specifically, just briefly, I want to focus on why this is happening to people. Now, it is, you know, labeled as the abstinence violation effect, but it's specifically related to the physical allergy. The idea that if someone takes a drink, they will then lose the power of choice. And also, let's say they consumed cannabis and they were someone who was using illicit fentanyl prior to that. According to the physical allergy, that individual will go back to using illicit fentanyl because they smoked cannabis.
Alcohol. It's not an allergy. There are some people who have a flush reaction to alcohol, and it's seen in people of Asian descent mostly. And for a while, again, this is a historical note, for a while people wondered whether the large amount of alcoholism in the Native American community was in some way related to this. It's a genetic defect. It was somewhere related to that. But when they looked at it, they realized that it's exactly the same genetic defect that is present in Japanese people. And the Japanese people have an extraordinarily low incidence of alcoholism compared to the amount that they drink. So that was out. But there is no such thing as an allergy to alcohol. So that part is wrong. I forgot what were the other two parts?
So physical allergy, mental obsession, which I would say you could equate to, you could say that's adjacent to compulsion, but that's not the way it's laid out with it.
Right. They don't really understand it. But okay. So what was the third one?
Spiritual malady.
Okay. So, yeah. Okay. But that's the same as saying there's something morally wrong with you, which is terribly harmful and stupid. But I want to get back to the physical piece because, you know, we haven't talked about it, but most people in the country believe that alcoholism is a chronic brain disease because about 25 years ago, the organization and it's part of the government, I'm blocking its name, where they studied alcoholism, came out with a statement saying alcoholism is a chronic brain disease. So what they did, it's a woman named Nora Bolkow who runs that agency. So what she said was, what they did was they did an experiment with rats. This is already important because what they found applies to rats, but it doesn't apply to people. I'll come to that back to that. So what they did was they took rats and gave them they gave them as a reward alcohol for completing a task. I'm trying to make sure I remember this right. And then what they did was this was like you remember Pavlov? Pavlov with his dogs back in 120 years ago. He trained dogs to have a reaction when he rang a bell and he fed them food. And after a while, he discovered that if he just rang the bell, they would salivate because they associated the food with the bell. So this was a reaction that he discovered. It's true. So the people, what they did at the National Institute of Alcoholism Abuse was they repeated the experiment with rats and alcohol. And they discovered, sure enough, that if you had something associated with alcohol, like the bell, that the animals would run around, something they called automatic behavior. I don't know why, but they said they'd run around seeking the alcohol, exactly like Pavlov's dogs. Now, the difference was that they could do something that Pavlov wasn't able to do. They cut up the brains of the rats without their permission, but they cut up the brains of the rats, and they found that they had an excessive amount of dopamine, the neurotransmitter dopamine, in their brains, that it was being excessively secreted. And so they concluded from this that the reason that the rats ran around was that the dopamine was being hypersecreted, oversecreted in their brains, and that made them run around. Then they made two giant leaps. They said that is the cause of alcoholism. And they also said, since it doesn't go away, this is a chronic, untreatable disease of your brain. And of course, they said that applied to humans, even though they had never done any experiments on humans. It would have been hard to do the experiments on humans because you'd have to cut open their brains. But there were many problems with this. For one thing, it doesn't fit the facts. As we've just been talking about, there are millions, tens of millions of people, whether in AA or something else, have had clear compulsive drinking, alcoholism, and stopped. Let's say they're in that 5 to 8% group that did well in AA. There is no other brain disease that you can cure by going to a church basement and talking to somebody. It just doesn't fit. The precipitant idea also doesn't work because you can expose people to exactly the precipitant that in the past has been effective without them doing it. Turns out people are different from rats. The kind of thing that I'm talking about, human psychology, doesn't exist in rats, as far as we know. There are no guilty rats. There are no rats who are filled with, helplessness and rage. So it just doesn't. It's utter nonsense. Recently, after many, many years, and of course it's treatable, obviously, but many, many years, Nora Volkow finally said it's a chronic brain disease. She said, but it's treatable. Those things are compatible only if you know what the cause of it is. You're treating the chronic cause, but she didn't have any ideas about how to treat it. It's just that she was bowing to the fact that people get better, for which there is no explanation in her mind. And let me give you the biggest final example of this, which I've also talked about in my books. Back in 50 years ago now, in Vietnam, during the Vietnam War, there was an enormous amount of heroin addiction because the soldiers had plenty of cheap, and we know now, very good, powerful heroin. And they were in Vietnam. So a lot of soldiers used it. And if you use enough heroin, no matter who you are, you're going to have a physical addiction. Okay. Well, this was known. So when the soldiers came back to the United States through California, they were screened for heroin addiction. Everyone who had a heroin addiction was sent to be detoxed. The person who did this study, named Rollins, she then followed up, 6 months later, she followed up all of the veterans, the ex-servicemen who had been through this program to find out if they had returned to drinking. Returned to heroin use. And she found that over 90% of them never used heroin again. Incompatible with the brain disease. They didn't have a brain disease. What they had was use of heroin in an extraordinary situation to manage. But the extraordinary situation was in Vietnam, not in their head. So when they came back, it was only their own psychology was at stake. They didn't need the heroin. They didn't have a disease. They didn't have they didn't have a physical disease, and they didn't have a psychological problem. They didn't use it. Completely blows away the chronic brain disease idea. So, but people don't listen. People like the idea because, it's nice to know you have a brain disease rather than you're immoral or have a spiritual defect.
Yeah. There's so much black and white thinking out there that I understand the implementation of the whole disease thing. I mean, when you look at the history and you look at kind of how, like Marty Mann, really lobbied, and there are a lot of different contributing factors that got 12-step to where it's at today. But it's just, it's very interesting when you look at the history, and I definitely encourage people to read The Sober Truth. And, there's some other books out there that are very informative. But, when we're looking at contributing factors, there are so many. There's, cultural, socioeconomic, all of these things. And what I really resonated with as far as your approach and your views is I've always, looked at this as being overstimulated. When I was, experiencing this firsthand, a lot of this was feeling completely hopeless and for me overstimulated, and I think that it's very human to then seek something out that can, calm you down a little bit, and to frame that as something that's insane. I just don't see that being productive,
When you say neurobiological, it brings up the question of physical addiction, which is real. But it's been historically confused forever. It's very much like the brain disease error. Physical addiction is real, but it's different from the psychological addiction that is the real problem. So let me explain. Physical addiction is physical. It has to do with the capacity of your body to react to some drugs, not all, by developing a tolerance to them. You don't have the same reaction. So if you that's not true for all drugs, obviously, but if you take Valium and you take it every day for a while, soon it will stop working because you have become tolerant to it. In fact, if you then take away the Valium, all of a sudden you have the reverse of tolerance. You have withdrawal, which can be dangerous. Same with alcohol. When you withdraw alcohol, suddenly you go into DTs or have another reaction. So physical addiction is real, but the confusing thing is that a lot of people who have psychological addiction develop physical addiction because they're drinking so much, but that's not the cause. And here's an example of why. Physical addiction is extremely easy to treat. That's what detox centers do. So if you go into a detox and let's say we give a random person on the street an experiment, they agree. For 10 days, we're going to have them drink a quart of vodka a day. Okay? We have to build up to it for most people. But then we do. After 10 days, are they alcoholics? No. But they will have an addiction to alcohol physically. You can't help it. So what do we do with them? Now we detoxify them. We put them into a safe detox. We gradually reduce the amount of alcohol. We give them one of the substitute drugs to help them get over it. And a few days later, we discharge them. They're no longer physically addicted to alcohol. Of that population, how many go on to become alcoholics? The answer is whatever is the average in the population. So if 1% of the population has alcoholism, 1% of those people, the point is making someone physically addicted does not turn you into an addict. It's physical. It's just different. So that's part of why people have forever confused the biology with the psychology. But anybody can have physical addiction without, and it happens all the time in surgery. After surgery, you're on Demerol or some other drug, which is physically addictive. You have to come off it. So we all hear about the cases where people can't, but the vast majority of people don't go out from the operation after they've been withdrawn and look for their local pusher. They don't. You don't become an addict by having physical addiction. So that's been another big mistake.
Yeah, and I think what you're speaking to is sort of the physiologic dependence that is constituted by developing tolerance and then subsequently withdrawal.
Yeah.
And so physiologic dependence is that some drugs will lead to a development of a physiologic dependence and some won't. And if you give people a drug that can lead to the development of physiologic dependence, that doesn't in and of itself lead to an addiction
Right.
or that compulsive use of that drug. Now, that's certainly the way I like to frame it to people is that it does require exposure to become addicted to that drug. And so exposure is a component, just like we understand that genetics can be a component, but they aren't the defining feature of addiction. We just see genetic trends that there can be a component in the development of sort of ongoing or compulsive use. But that exposure is certainly a criteria, and then the rest of that is environmental. It depends on what, in the context of the story you told, it was the sort of traumatic experience of somebody had in childhood that led them to become overwhelmed, and their compulsive use helped them sort of quiet that sense of overwhelm. Or Macaulay, what you were talking about, feeling overstimulated and seeking something that would turn the volume down on that overstimulation. So I think there's a combination of components there. I think we can acknowledge that there are sort of neurobiological changes that happen in relation to chronic use of substances, that can impact psychology, not just a physiologic dependence. And so that is where I think some of the ideas about treatment beyond just psychotherapy and addressing the root of the problem can be helpful. So I think one of the things that I'm curious about, because we do with substance use as opposed to other sort of behavioral disorders, that we know that substances can impact the neurobiology of individuals, like in their brain chemistry and in their reward patterns. And we see it on functional imaging, for example. In terms of defining substance use disorders or compulsive use as opposed to other behavioral disorders, do you find a distinction between those? Do you see a difference in the way you view them?
Well, no, because as I said, if you think of addictions as compulsions, if we eliminated the word
Right.
addiction, which actually comes from physical addiction, we don't need
Right.
it. So the way I would treat someone who was, let's say, compulsively exercising, or there are a lot of people around who are compulsive workers too, right? They can't stop, and it's all right. So I don't think there is any, for them, I don't think there is any physiological piece to that. It's compulsive. And I would treat them, I would treat them in therapy. I would say, look, let's understand what's going on. The person would start to tell me, well, the reason I overwork, I've always overworked. I say, how come? And they say, well, I don't know. It was my whole family overworked. I was taught from the beginning that that's how you become a good person. You contribute to society, but beyond that, also, it made my father proud of me. And there are a lot of reasons why I do it. So now we understand something where it comes from. So now we say, okay, so these days, when you're overworking, what goes through your mind when your wife says, I wish you wouldn't spend so much time at the office. So what happens? Well, I wish that I could help her, but I've got to do this. So, this is not a 1 hour treatment, but eventually we're going to look into it and what actually is driving him to do this behavior, as we would for any psychological problem. And there's no stigma, there's no particular physiology to it. And people get better in psychotherapy because they understand themselves. They become, the world's expert on themselves. So no, I don't see much difference. I do think that I'd like to think that the contribution I made about understanding it as a compulsion, as a response to overwhelming helplessness driven by this kind of normal rage, I think it's important for people to understand, because it takes, as I say, it takes away all this other stuff. And by the way, just one other thing, recall you mentioned the sober truth, which I'm glad to have you mention. But that book is about AA, and since I mentioned to you before we got on, the reason I wrote these books is because I've written all sorts of things in academic journals, but no one reads academic journals. Even the academics don't read academic journals, let's face it. So, I wanted to get my ideas out to the public because we have a terrible system now, which is costing lives. So I want to promote The Heart of Addiction and Breaking Addiction. I promise you, The Heart of Addiction, every time it sells a book, I get 0. I'm telling you that. That's the truth. It's not that, but I want to promote those ideas.
Well, thank you so much. As always, this is the Recovery Reform Podcast, here with my co-host, Dr. Taylor Nichols. Please like and subscribe if you're watching this on YouTube, and I hope everyone has a great day. All right, bye. The views and opinions discussed on this podcast are personal and do not reflect the views or opinions of our employers. Although medical and clinical topics may be discussed in this podcast, the information provided is not medical nor clinical advice. Thank you for watching and/or listening.